Hello, this is Dr. Laura Tigler. Welcome to my channel. This channel is meant to provide medical information. It's not meant to provide specific medical advice, so please do see your primary care provider or your primary care doctor to obtain medical advice that is specifically tailored for your needs. At the end of each video, I will provide some spiritual information. If you do not want to stay for that portion of the video, at the end of the medical information, I will let you know, and at that point, you can simply click away. And finally, please like and subscribe. So today's topic is COPD. I imagine I am going to be doing several videos on this topic. It's a huge topic, but today we're going to be giving some basic information. COPD stands for chronic obstructive pulmonary disease, COPD, and it's a chronic lung disease that causes inflammation in the airways, not just inflammation in the tube, the airway, but also the airway itself, the tissue of the tube, let's say, does have some damage. So it's inflammation and some damage of the tissue of the lungs. COPD is not curable. And then this problem leads to obstruction of the airflow going out. So I'm going to breathe in 3 times. I encourage you to do that with me. And I could feel my shoulders relax. So I'm going to ask you to inhale with me and exhale with me. And I don't know about you, but even on that second inhale and exhale, I felt I could get more air in, and I felt even more relaxed. Let's do a third one. What a great feeling for so many reasons. But just imagine if you had COPD and you weren't able to breathe smoothly like that. Okay, so let's move on. Causes. Smoking is the #1 cause for COPD. Smoking actively, so let's say I smoke 1 pack per day, every day for 40 years. So we call that 40 pack years. There's a certain way we calculate that. Incidentally, if you have smoked 20 pack years or more and you're over age 50, we do have a lung cancer screening test. Please do ask your provider about that. But also passive smoking. So I told you active smoking is a problem, but passive smoking, it just means that you're not the one actively, you don't have the cigarette in your mouth, but say a person next to you who you're with all the time, maybe in your home or a coworker at work, is smoking. And so you're getting a lot of smoke inside your lungs, even though you didn't inhale it directly. So that's passive. So whether it's active or passive, smoking is a huge risk factor for COPD. And then exposure to air pollution, dust, irritants. This is a long list of chemicals or smoke or dust that we could go over. But you could think of contemporary situations that are causing problems. So let's say the Canada wildfires and the smoke from those wildfires, and they're going down to, say, big cities like Chicago. You've seen those pictures on the news, or New York City. So large portions of the United States are being affected by an area of the world pretty far away. And then there could be wildfires, say, in California, Oregon, and then the wildfires in California can even keep spreading east. The smoke can spread east and affect people in other states like Nevada. Or there could be wildfires in Arizona, Utah. And so we're all sharing the same air. So that's a good contemporary situation that you can imagine that can cause damage and problems for the airway. Symptoms of COPD, chronic obstructive pulmonary disease, persistent cough. So persistent cough could be from other causes, of course. We've mentioned that cough can even be a symptom of heart failure. You might want to go back and listen to the heart failure video. Of course, cough can be a symptom of other conditions like acid reflux. But in this case, for COPD, it can be a symptom. Persistent cough can be a symptom of COPD. And then when the person has the cough, sometimes they could have some mucus come out. And it might be similar every day. It's chronic, going on every day. Shortness of breath, and that probably makes sense to you because you and I breathe together. And probably most of us had some smooth airflow. But the COPD patient doesn't have smooth airflow. When they're breathing out, it could be obstructed. Their breath feels short. Shortness of breath, that's how we describe it. And they can have shortness of breath with inhalation, but particularly with exhalation. And then the shortness of breath can be present sometimes only when the person exerts themselves. Like, let's say, I'm going to go check my mail. Every day at the same time, when I go check my mail, the mailbox is outside, I can't breathe. It could be from pollutants in the air, it could be from the exertion, but that is something the patient has to pay attention to and let their provider or doctor know. Wheezing can be a symptom of COPD. It's not just a symptom of asthma, so please do tell your doctor if you're having wheezing. Don't just assume it's asthma. Chest tightness, obviously chest tightness can be a symptom in other conditions. It could be chest tightness from a heart problem. It could be chest tightness from other conditions, but COPD can have a symptom of chest tightness. Fatigue, I think that makes sense to you. I mean, work of breathing, that's something you might hear us physicians say. They're getting fatigued because of the work of breathing. So it's a lot of work to get the same level of oxygen in the blood that person would have gotten if they didn't have obstruction of the airflow. So they might be concentrating in their breathing. They might have to use their accessory muscles and put their hands on something and to help get a full inhalation in and exhale. So everything I just did, I was concentrating, I was trying to move my body in a certain way, I was focused on the work of breathing. And that can make you tired. And then increased respiratory rate. That's something you might not notice, but as I've talked about in several other videos, we check the vital signs when you come in, and they are vital. And one of those vital signs is how fast you're breathing per minute. So we'll catch that even if you don't catch that. Diagnosis. So the diagnosis is made by spirometry. You might know that as a breathing test. You might know that as a pulmonary function test or PFT. All of those names are for the same thing. So basically, we have you breathe out. Of course, you're going to breathe in. There'll be a tube in your mouth, and you'll breathe out really hard, really fast. And if any of you have had this breathing test, you'll know that the nurse or medical assistant will keep saying, go, 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 go. They'll want you to breathe out, to keep breathing out, even if you feel like there's nothing left in you to breathe out. But follow their instructions exactly. Do your best because you want your attempts to be successful. You want a diagnostic test. You want to know, do you have COPD or do you not have COPD? That is the test. So try to be as good at the test and listen carefully to the instructions and follow the instructions. So that is very important. Chest x-ray is a very common diagnostic test. Basically, I can't say for sure that you have COPD based on the chest x-ray. I can't necessarily even say for sure based on the CAT scan. The breathing test is the diagnostic test. But for example, with a CT scan or CAT scan of your chest, the radiologist might say something like background emphysema. So we can actually tell on the CT scan of the chest if your airway has some damage. So the very lowest level of your airway is the alveoli sac. You might just call it airway sac. Very tiny, and that's where the exchange of oxygen and carbon dioxide occur. And unfortunately, in COPD, in many cases, there's damage to the tissue in those air sacs, and then we can see that on the CT scan of the chest. So if I see that, I might say, I might put it in the problem list of the patient, and I'll say emphysema as per CT scan, but I really can't officially label you with COPD until I get that breathing test. But the imaging studies are very helpful. Physical exam is very helpful. So I am old enough to remember when the physical exam was much more commonly used. But back when I was training, because I've been practicing almost 25 years, we did have CT scans. It's just that listening to the person's airway, generally putting the stethoscope on the back and having the patient breathe in, and out, and I might even have the patient cough. So I can listen to see if there's inflammation or junk or phlegm or sputum in the air sacs, in the airways. It's still very helpful, but the spirometry is the gold standard, the diagnostic test. But the physical exam is still helpful. So the treatment for COPD, I wanted to break a couple things down for you before I talk about the treatment. There are a few types of COPD. COPD is an umbrella term. And underneath that, we can have chronic bronchitis. We can have emphysema. There are other conditions that we can have underneath the umbrella of COPD. There is one particular genetic condition that can be a type of COPD, and I will talk about that in another video, I hope. And then there can be genetic factors not related necessarily to your exposure to smoke or the environment, like we were talking about the Canadian wildfire smoke. So there are a lot of types of COPD, but generally COPD is the most common, let's say, is the emphysema type, where there's damage to the airways. Years ago, we used to say that was irreversible damage. And I think I said at the beginning of this interview, and if I didn't, let me say it, that COPD is not curable. And that is true. But in recent years, we have found that there is a bit of reversibility with it. So that's kind of good news. Okay, so treatment. Smoking cessation is essential. Do not be around anyone who smokes cigarettes. Do not smoke cigarettes. Completely cut that off from your life. There are medications to open the airways. We'll talk about medications in a moment. There's medications that are anti-inflammatory. There's oxygen. And there's also pulmonary rehabilitation. And your primary doctor can order that. At least I can. I treat seniors, and I treat serious chronic conditions. So please do ask your provider. If you know you have COPD, and let's say you're exposed to some aggravating factors like wildfire smoke is coming to you not infrequently now, or other things, you might ask your primary care provider, can you please order pulmonary rehabilitation? That's perfectly okay. And basically that's physical therapy for your lungs. So COPD is a progressive disease. I already told you it can't be cured, but it's something that we have gotten very good at managing, and we can improve your quantity and your quality of life. This is very worthwhile to get diagnosed, evaluated, and treated. It's going to give you a lot of benefits. And as I alluded to, early diagnosis and treatment are important. Okay, so I want to give you a list of medications. I hope to do a subsequent video where I can talk about each of these medications in nauseating detail, or at least some detail that maybe you might enjoy and might be enlightening for you. But right now I'm going to give you a list. So medications for COPD fall into several classes, including inhaled bronchodilators. So as you can imagine, that's helpful because if there's inflammation or gunk in the airway, or the airway, parts of the airways damaged, this long cylinder, let's say, then you want to maximize the flow of air. So it might be helpful, and it is helpful, to make that pipe or that airway a larger diameter so that more air can flow through there. Okay, so bronchodilators do help with that. And we have short-acting bronchodilators and long-acting bronchodilators. Please do ask your physician or provider what type you have, and at the very least, you should have a consult with your pharmacist, and you really need to have someone show you how to use these inhalers properly. It's very important. Okay, so inhaled corticosteroids is another class. And if you know anything about medications or medicine, you'll know that steroids are an anti-inflammatory. It's just that typically when we doctors say anti-inflammatory, we're thinking of the non-steroidal anti-inflammatory drugs like ibuprofen, Motrin, Advil, naproxen, naproxen, Aleve. Those are anti-inflammatory. And if I do have some seniors listening, meloxicam is in that class as well. There are other anti-inflammatories. I was just listing the over-the-counter ones so people can right away know what I'm talking about. So when we say anti-inflammatories, we're typically talking about that class that I just listed. But steroid is basically an anti-inflammatory as well. But its effect is much more broad in your body. There are many effects, not just anti-inflammatory. So if you do get, say, oral steroids, that's a whole nother class of medication and potential side effects and problems, but also good things that you need to learn about from your physician or provider. But we do try to minimize systemic, or that means by your mouth or a shot. We try to minimize systemic steroids for those reasons. But we have learned over the years that when you inhale steroid, so I might have an inhaler, and if I use a spacer, so the medication is here, this L shape, and then this is just a spacer. So the large particles of the steroid land in that spacer, and then there's a tube coming out of the spacer that goes in my mouth. That means that we're trying to minimize the particles of steroid landing in the oral cavity, the mucosa, the buccal mucosa, which is your inside of your cheeks and even your throat. And we want the medication, that steroid, to actually be inhaled and land on the surface of your pipe, your airway pipe or airway. So inhaled corticosteroids are anti-inflammatory, and then the inhaled bronchodilators dilate the airway. So those are two different classes. And then we have combination inhalers. And then we do have some other classes, which I'll touch on with this list I'm going to give you. So I'm going to give you some names. So for the short-acting bronchodilators, it could be albuterol. That's a very common generic name. It could be Proventil. It could be Ventolin. So you might be familiar with some of those. Long-acting bronchodilators. Now we abbreviate it and we say LABA and LAMA. That's how we talk. And I really want you to be aware of this, because sometimes we're not going to say the whole word. We're not going to say to the patient, oh, this is a long-acting beta-2 agonist. I mean, even though we should. We might say this is a LABA and this is a LAMA, and how it works is it dilates your airway. That's perfectly fair. So you really need to know LABA and LAMA. It's just an abbreviation of LABA is long-acting beta-2 agonists, and LAMA is long-acting muscarinic antagonists. And these descriptions, it's okay if we kind of don't go over those details in the office visit, because they're really just describing exactly how it works on a molecular level. And really from a patient point of view, you probably just want to know, does it dilate my tubes or doesn't it? So it does dilate your airway tubes. Okay, and then the next class is the inhaled corticosteroids, and we abbreviate that ICS, although we won't generally talk like that with the patient. We'll probably say inhaled steroids. We'll still shorten it, but we probably won't say ICS, even though when we type things or talk to our colleagues, we'll use ICS, inhaled corticosteroids. Example would be Flovent, and the generic of that is fluticasone, budesonide, and the brand name of that is Pulmicort. And then there are combination inhalers. You could mix an ICS and a LABA, and then you might be familiar with Advair, which is fluticasone and salmeterol combination, or you might be familiar with Symbicort, which is budesonide and formoterol. So I'll talk about these in another video, because I do need a lot more time to go over the medications. Those work very well, but they only have 2 ingredients. We're tending to move over to the medications that have 3 ingredients. We're finding out that those work much better. because we want to keep you out of the hospital and we want to prevent a premature death. COPD is going to cause, you could think of COPD as causing a premature death. It's the third leading cause of death in the United States. So it probably will cause a premature death, but we're trying to lengthen the quantity of life to give you more time. So we might combine ICS and LABA, and that's Advair and Symbicort, and then we might combine LAMA and LABA. So some of you might be on Stialto, and that's tiotropium and olodaterol. Although I don't often say those generic names, like even though it's generic now, I might still say the brand name because, as you know, the the names for the medicine sometimes can be very difficult to pronounce. Okay, sometimes with COPD, it's not just like a steady as she goes problem where you have a certain level of cough and a certain amount of sputum production. It could be that, let's say you wanted to go to an outdoor concert and everything was going well and you thought, yeah, I can do this, and maybe you even wore a mask and tried to minimize your exposure, but you still were exposed to some irritants in the air, whatever it might be, and then you couldn't breathe. And there's more sputum coming out. So there's more inflammation being made in your airway, and there's more obstruction of your air coming out. So we call that a COPD exacerbation. When that happens, you'll want to have an antibiotic and a oral steroid. That means generally by mouth. We don't typically give steroids shots in the muscle for a COPD exacerbation, at least not in the outpatient setting. And so that might be something like a Z-Pak, which the generic name is azithromycin. Another name for it is Zithromax, but it's all the same thing. It's a macrolide type of antibiotic. Or it might be something like Levaquin, and the generic name for that is levofloxacin. I got it. And that's in the fluoroquinolones. So there's two different classes of antibiotics that we would consider. And then we want to give you a steroid, an oral steroid. So often we'll give prednisone, say 20 milligram once a day for 5 days, or prednisone 20 milligram twice a day for 5 days, something like that. Or we might give a tapering over 6 days, and we call that a Medrol dose pack. There are lots of caveats with that, so please do ask your doctor about details for those medications. Like I said, we'll probably go over that in another video. But typically we might combine an antibiotic and an oral steroid if you have a COPD exacerbation. Okay, an old medication is theophylline. I am old enough to have used that. It's very rare to see a patient on that. Most of my patients have serious chronic diseases. Most of my COPD patients will also see a pulmonary physician. And then throughout the years, they'll be switching their patients from the old medicine, theophylline, to the newer medications. But every now and then, rarely, I might see a patient that's still on theophylline. But it is a bronchodilator, and it works differently than the bronchodilators I mentioned earlier. Leukotriene modifiers, sorry if I didn't pronounce that perfectly, but think Singulair or Montelukast. They may be considered by some healthcare providers. It's not too common, but sometimes that is helpful. And that's a pill you take once a day. Again, that can have side effects. All of these can have pros and cons, so you have to talk about this with your provider. If you're listening to this video and you have a family member that has COPD, make sure that you get details and instructions from the provider for your family member. Don't treat them yourself or just go by this general information that I'm giving you. You really need a good primary care provider who's knowledgeable, and even preferably also a pulmonary specialist, which means a lung specialist. And then over-the-counter Mucinex. Mucinex is the brand name, and then the generic name is guaifenesin. And that one, you do have to drink plenty of water with that. It really works in combination. So the Mucinex is a mucolytic. It kind of breaks down the tightness and dryness of the gunk. And then the hydration in your body is going to kind of help that process to break it down. If you're not well hydrated, it's not going to work. But there are times where we will have patients on the Mucinex type drug twice a day, every day. Or sometimes we'll do it just as needed. And then the last thing I want to recommend is to keep your vaccinations up to date. If you're going to have just 2 vaccines, if you have the diagnosis of COPD, the 2 vaccines you should have is the flu shot every year, and if you're over age 65, the higher dose flu shot. Talk about this with your doctor. And the pneumonia shot. We call that the pneumonia shot. Before I get to the pneumonia shot, the flu shot is really to protect you against influenza. We just don't use the word influenza very much. It's just so well known since the pandemic in the early 1900s. Almost everybody knows the flu shot is for influenza. So we do abbreviate that and we say flu shot or shorten it. So that, just so you know, it's for the virus influenza. But for the pneumonia shot, we also shortened that. So pneumococcal is the bacteria class. There are many different strains that can cause pneumonia in that class. So since it can cause pneumonia, not that the flu and other viruses can't cause pneumonia, but since the pneumococcal bacteria strains can cause pneumonia, we just abbreviate that and we say pneumonia shot. Sorry, but that's how we do it. So flu shot, pneumonia shot. And I will go into more details about those later too. But if you're going to have just 2 vaccines, if you're age 65 and older, there's about 7 to 10 different vaccines that are recommended. And if you're only going to have 2 of them, these are the 2 you really should have. Okay, so that's the end of the medical information for COPD. I hope to give more videos on this subject because what I've told you is pretty basic, and I really want to delve deeper into COPD. But that's the end of the medical information. So if you do not want to stay tuned for the spiritual information, then you can click away now. But first, please do like and subscribe. Okay, so what I tell my viewers when we get to the spiritual information portion of the video is that I am a devout Christian. I am saved, and I wrote a book about that. And in some videos, I show you that book. It's called You're Saved by Laura Tigler, and you can type that into Amazon. I also have an author website, which is in the description of my channel. Please feel free to go there. Feel free to go to Amazon, look for my first book. It's theological in nature. I humbly submit that it's excellently written and engaging, so I think you'll enjoy it. And I usually say a prayer from that book. But the reason I bring up this spiritual information is because having practiced almost 25 years, I've noticed that patients who have a spiritual discipline or a religion or a faith or even close family ties, something that is bigger than their personal story. There's a bigger story in their life, something with a lot of meaning in their life, and they have a deep faith in that way. Those patients seem to do better, and the scientific literature does bear that out to some degree. So I want to, instead of saying a prayer from the book I just mentioned, I'm just going to read a very brief excerpt from my second book, which is a work of fiction. It's really just meant to entertain. Please take it for that. In my author mind, I thought of it as a work of art. I thought of it as imagination, creativity. It just came out. It was very creative. And I do humbly say that it was very well written. It's a much shorter book compared to the first book, and I think it's a good book to read, say on a vacation or at night. Read a chapter and then go to sleep and read it. Do not read it to kids, though. It does have adult content. Okay, so I wanted to just read a brief portion of that. So if any of you are Christians, you can definitely relate to the hero of the book. She is a woman of faith. And then if any of you are Hindu, from the Hindu religion and culture, you can relate because I do have a lot of characters from India. And then the Christianity and Hinduism intertwine somewhat, and it can make us feel a little uncomfortable, I must say. But I enjoyed writing it. I feel like it's okay to be open to other beliefs. And remember, this is the book just to entertain. Okay. All right. So I'm going to read chapter 11, Arabia's Planet. Lara was overcome to meet Jesus here. She and the boys had only arrived yesterday. Space travel was completely new to Lara, not to mention to her 2 children. They had been taking so much in. It just never occurred to Lara that she would have such a direct, mystical experience while doing her space travel training. All of her time travel experiences on Earth had been more along the lines of simply completing a task. The transition from her own time to the new time was always somewhat mystical, but it was very brief. Laura had to be quick on her feet, literally. Jesus was showing her to her seat in the stadium. So you can buy this off Amazon to see what happens next. All right, so I'm really excited to talk about COPD. I hope you enjoyed the video, and I will see you next time.